Welcome to Somerville College at the University of Oxford. My name is Justin, and today we'll be talking about medical imaging, in particular the diversity of technology that we use in the clinic, but also the diversity among the people who do medical imaging research. Now, throughout this talk, I'll be asking some questions, so I encourage you to answer in the chat. So here comes the first question. I've shown four images that we commonly acquire in the clinic. So first, which image is ultrasound? So I see a lot of twos. So 2 is correct. 2 is showing an ultrasound image of a baby inside the mother. Now, which of these images is the optical image? So I see a lot of ones coming in. So 1 is correct. 1 is an image, an optical image of the esophagus. And so the other two modalities I'll be talking about are computed tomography, also known as CT or CAT scan, and MRI. So which of these images do you think is the CT image? So I see a mix of 3 and 4. Both CT and MRI are commonly used to look at the brain. In this case, 3 is the CT image and 4 is the MRI image. So we'll be using these imaging modalities to have a look at our patients in the waiting room. So today we have lime, avocado, starfruit, and strawberry. So we'll be taking a close look at all of these patients using the diversity of imaging techniques that we have in the clinic. So first, let's look at optical imaging. Now, most of you will be familiar with optical images. So what we're looking at is basically signal in the visible part of the electromagnetic spectrum. And we're looking at reflected photons. So these are particles of light that reflect off these images. And to acquire our signal, we use a detector, also commonly known as a camera. And so here, what we can see are the optical images of our patients. What you can see is our properties like color, so surface color, surface texture, size and shape. So what we can see, so lime and avocado look a little bit green, so perhaps they're not feeling their best. So we'll have a look at them. Starfruit is looking a little bit shabby, and strawberry looks a little bit smushed. So perhaps the starfruit and the strawberry might have a skin condition. So we'll have a look using the other imaging modalities to see how they are doing. Now, in terms of looking at the fruits, we're seeing mostly the surface, and that's because with optical imaging, the depth of penetration is very low, and so you don't really see very far deep into the fruits, but that doesn't mean that we can't see inside the body. We actually have cavities in the body where we can insert a camera. And this device is a medical device known as an endoscope. So here, an endoscope is a long flexible tube. And it has a bright light and a fiber optic cable attached to a camera. And so here you can see the technician inserting the endoscope down the esophagus of this dummy that we use to train our medical students, but also our technologists. As you insert the endoscope down the esophagus, you can see the optical images of the inner surface of the esophagus, and that can be very useful in looking at the condition of the esophagus and also any diseases inside the esophagus. So here comes the next question. Have you ever experienced heartburn? Vote in the chat, Y for yes, N for no. So I see a kind of a mix of yes and no, which is absolutely normal. every now and then, all of us, or most of us, will have experienced heartburn. And heartburn is a burning sensation in the lower part of the esophagus. So how it works, so what heartburn is when the acid in the stomach accidentally gets flowed backwards. So at the bottom of the esophagus, there's actually a one-way valve known as the lower esophageal sphincter. And that valve is supposed to allow food down the esophagus into the stomach, but it's supposed to prevent a backflow of the acid in the stomach from going back up the esophagus. And so normally this sphincter, when, for example, when you're lying down, this sphincter will be closed, and so the liquid will stay inside the stomach. But sometimes, from now and then, the sphincter will be too relaxed, or it will fail. And in that case, the acid might go up the esophagus and affect the lower part of the esophagus, and the cells that line the stomach are quite different from the cells that line the esophagus, and so when the acid touches the cells in the esophagus, those cells are not prepared, or are not well adapted for the acidic environment, and so you feel a sensation of pain. Now, as I said, every now and then it's normal to have heartburn, but if you have heartburn too often, then what can happen is the lower part of the esophagus can become chronically irritated and can be inflamed, and the inflammation can increase your risk of cancer. And so this is a very good example of something that we can use endoscopy and optical imaging to look at. So if we insert the endoscope down the esophagus and look at the esophageal sphincter, we can see whether or not the cells have in the lower esophageal sphincter and the lower esophagus, whether those cells have changed in appearance. And in this case, what we're seeing here is an early sign of cancer, and this is a condition known as Barrett's esophagus. And so if you have too much irritation, too much inflammation, you can eventually develop, you have a greater risk of cancer, and eventually you can develop either scarring or some sort of malignancy in the lower part of the esophagus. And so optical imaging here is a very useful modality for looking at these particular conditions in some of the inner cavities in the body. Okay, so the next imaging modality that we'll talk about is ultrasound. Now, ultrasound is actually somewhat of quite a common technology that is used by the various animals in locating their food. So the common examples are bats and fish. So what they do is they send out a sound wave, and it's a pulse and acquire type of imaging. So they send out a sound wave, and then they receive, so they listen. So they send out sound wave, and then they listen for the sound to come back. And in fact, these animals are much more sophisticated than even our most advanced ultrasound technologies, because these animals can process the echoes that come back in their brains in real time, whereas it takes us some effort in order to, and quite a lot of technology in order to render the echoes that come back into an image. But how it works is it's a pulse and listen type of technique. So here I've shown our object, which is the baby inside the mother, and our transducer, which is made up of different elements that can both emit and receive sound. And so what we do is we emit a sound wave, and then we listen back for each channel in sequence. And based on the amount of time that it takes between the transducer emitting the sound and the sound being reflected and then returning to the transducer, we can calculate, based on the speed of sound, the distance that the sound wave traveled before it hits a boundary. So let's look at what happens with our first channel. So here we emit a sound wave, and then it bounces off the top of the baby's head and then comes back. And so based on the time delay, we can calculate the distance based on the speed of sound in water. And so here we have our first point in our image. Now we continue down the transducer, so let's look at our next element in the array. So again, we emit a sound wave, and then we listen. But now, because there are two boundaries, one on the front and one on the back of the baby's head, we actually get two echoes, and so we get 2 points on the image. And then moving further down, we repeat this process, and again, with this particular sound wave, we get 2 echoes, again from the front and the back of the baby's head. And so what you can see is as we go down the transducer, go down the different channels in the transducer in sequence, eventually we can observe all the reflections and the locations of where the reflections come from. And so we get an image of the boundaries. So these represent the boundaries between materials that have different acoustic properties. And so ultrasound is really good at looking at differences in texture of the object, so different boundaries between materials that have different acoustic properties. Now, ultrasound machines are quite small, and one of the benefits is that they're portable, so they come on wheels, and so we can do ultrasound imaging at the bedside. And so ultrasound machines use a detector known as a transducer, and transducers come in a variety of different shapes and sizes. So what I showed you previously was a linear array. So this is basically just a sequence of channels arranged in a line. And so by emitting sound and listening to reflections one channel at a time and going, for example, from left to right of the transducer, then you get an image. Now, there are also curvilinear arrays. So these give you a wider field of view, and because of the geometry, you can see a little bit further, a little bit wider. Get a little bit wider of an image, and this is very useful when trying to image the baby inside the mother, because sometimes you don't know where the object is supposed to be necessarily, and so the curvilinear array gives you a wider field of view, so it's easier to find what you're looking for and then place the transducer closer to the object that you're trying to image. And then the third one on the right is the phased array. So this is kind of a newer technology where instead of having the curvilinear array where it's based on the geometry, the curved geometry that gives you the wider field of view, the phased array looks more like a linear array. But what we can do is we can use computer-generated signals and play those out among all of the channels in order to create a steered sound wave. So this can be directed at a particular angle into the object. And so in this way, we can simulate what we get with a curvilinear array with a much smaller linear array-looking transducer. So the first step usually in ultrasound imaging is applying the gel to the patient. So why do we need ultrasound gel? Well, you can see here, this is a transducer without the gel. And so what you can see on the screen is basically just the surface of the transducer. So what happens is the difference in acoustic property between the electronics in the transducer and the air is so great that basically all of the sound waves, once it leaves the transducer, it gets reflected by the layer of air immediately above the transducer and comes back. And so what you get as an image is basically just the surface of the transducer, which is not so useful. So what we would like to do is to acoustically couple the transducer to the object that we're imaging. So the easiest way to do it would be to basically submerge the object in water and then image the object underwater. Now, this is not very practical in the clinic. So the better alternative is to apply an ultrasound gel, which is mostly water, so basically thickened water. So let's have a look and see what happens when we apply the gel to the transducer. So here comes the gel. So you can see when you apply the gel, the sound goes further, like deeper through the gel. So when we put the transducer on the object, the gel acts as a coupling to provide a liquid interface so that the sound can go from the transducer through the ultrasound gel and then into the object, and then the echoes come back as well through the ultrasound gel into the transducer. And that way you don't get as much sound loss due to reflection at the air boundary. Okay, so let's have a look. Let's have a look at our first two patients. So here, let's have a look at the starfruit first. So here's our starfruit. So what I'm doing is basically imaging one of the fins of the starfruit. So you can see here, as I move the transducer across one of the fins, you can see the shadow of the fin moving left to right as I move the transducer across. Here I will just use the transducer to follow the fin up towards the tip of the starfruit. And hopefully you can see maybe a little bit of features, a few features in the tip of the starfruit. So there's some indentations, there's also different fins that start to appear. And here what I'm doing is moving the transducer left and right across two fins at the same time. So here you can see two shadows moving together. And now I just move the transducer to the other side and then have a look at another fin. So again, you see a shadow moving left and right as I move the transducer across the starfruit. Okay, so now next let's move on to strawberry. So let's have a look at the strawberry. So I have strawberry here. So again, we put the ultrasound transducer on the strawberry, and what you can see are a little bit of bumps near the surface. These bumps come about because strawberries have seeds on the surface, and so the seeds are quite hard and dense compared to the soft tissue of the strawberry, and so the ultrasound gets reflected more from the seeds than from the soft tissue. And so you see these black shadows on the ultrasound image. So far, what we've seen is ultrasound is very good at looking at surfaces as well. So similar to optical imaging, but maybe we get a little bit more depth of penetration. Okay, so let's move on to our next patients. So here comes avocado. So I have avocado here. So what I'm doing is I'm moving the transducer across the avocado. So let's have a look at the image. So you can see mostly just a very big shadow cast by the avocado. You can see maybe a little bit of the texture of the skin of the avocado, so a little bit of the wrinkles on the avocado skin. But more or less, it's just a great big shadow that goes across as I move the transducer across the avocado. Okay, so let's have a look at lime, see if it's any better. So here I am, so here's lime, and then I'm moving the transducer across our lime. Again, we mostly see just a shadow of the lime. So in these two cases, what's happening is the avocado and the lime have much thicker skins compared to, say, the strawberry. And so a lot of the sound waves get reflected off of the skins. So let's have a look at my hand. So here I'm moving the transducer down my hand. So kind of like this, kind of moving the transducer down my hand. So what you can see are some dark shadows as I move the transducer down the length of my hand. And so those dark shadows represent the bones in my hand. So bones are very dense. And so similar to the avocado and lime skin, the bones tend to reflect all of the sound back. And so in those areas, you don't really see anything behind the bones. And so you can see a little bit of the soft tissue in my hand, and then the bones, but perhaps ultrasound is not the optimal modality for looking at bones in the hand, for example. If you have a broken hand, perhaps it's not the best modality to choose. So, okay, let's move on to our next modality, which is computed tomography. So like I said, the common acronyms are either CT or CAT scan. So computed tomography uses X-ray technology. So first I'll talk about the very, very old technology, the first application of X-rays in medicine. So X-ray imaging was discovered in 1896 or 1895 by Wilhelm Röntgen. And it was discovered somewhat accidentally when Dr. Röntgen basically put his hand between an X-ray source and a photographic film. And so here on the left, there is the X-ray image of his wife's hand with a ring on her finger. So this is quite a remarkable imaging technique because it allows us to see the bones, the bony structures in our hand. And so the next year, in 1896, Dr. Röntgen presented these results at a conference. And so here in the middle is a slightly updated image, a little bit higher quality, but more or less showing the same thing. So the bones in the hand and also a ring that the subject was wearing. And then on the right, I'm showing a modern image. So this one from 2010. Basically, the technology hasn't changed very much. So the quality of the images might be slightly better, but overall, there's not much change in the past over 100 years. So it's quite a old technology. It's a tried and tested technology, but it hasn't really moved so much in terms of technological advance. So how it works again, so it's a projection type of imaging. So what we have is a X-ray generator, and that produces a beam of X-rays. So for example, the X-ray source at the top, and then you put your hand just below the X-ray source, and then you have a photographic film or an X-ray detector at the bottom. And so it's very fast. So when you turn on the X-rays, it's basically the speed of light. So the X-rays go into your hand, and some of the X-rays will get absorbed or reflected or scattered by your hand. So usually the denser parts of your hand will scatter and reflect and absorb more of the X-rays. And so what you're receiving, your signal, is basically looking at the X-rays that are not absorbed or reflected or scattered. So those are the X-rays that pass right through your hand and then get detected by either the photographic film or the X-ray detector. And so what you see is basically the whole thickness of your hand gets projected down onto a two-dimensional image. So that's what we mean by projectional radiography. It's basically the full thickness, but squashed down into a 2D representation. So here we're looking at the radiograph of the arm. So you can see the two bones of the arm, and also you can see a fracture. So this is a very good technique for looking at broken bones. Another common area, and perhaps one of the most useful and most commonly used imaging modalities in the clinic is the chest plain film X-ray. So this is basically a projection through the patient's chest. So what we see here are, of course, the rib cage, the bones. We see the spine down the middle, but we also see the two lungs. And the two lungs show up a little bit darker than the rest of the image because the lungs are filled with air, and the air is much less dense than the rest of the body, and so it tends to reflect and absorb and scatter less of the X-rays. So you can see the lungs. You can also see the heart in the middle and then slightly to the left. So here on the top of the image, there's two labels. These are in Latin. So there's on the right, there's a DX. That stands for dextra, which means right in Latin. And on the right side, it says sin, which stands for sinistra. Which is left in Latin. And so when you're looking at these plain film X-rays, the conventional orientation is as if you were looking at the patient at the face, directly at the face of the patient. And so their right side is on your left side. And so it's kind of a mirror image. You can think about it, a mirror image of yourself, perhaps. So on the left is a normal plain film X-ray of a healthy chest. So you can see as well at the bottom. You can see on the left side there's the liver, and on the right side there's actually a bubble in the stomach. So so what we can do is we can have a look at a patient who is not doing so well. So on the right, we have a patient who is showing some increased opacity in the lungs. And so you see a little bit of consolidation within the lungs, which indicates that there's most commonly a buildup of fluid. So this can either come about due to a condition such as pneumonia, or it could indicate inflammation in the lungs. And so there's just a bit of additional fluid, more fluid than normal in the lungs, and especially here on the left side. So on the right side of the image, which is the left side of our patient, there's quite a bit of consolidation on the lower lobe of the lung, and so from the plain film X-ray, you can tell immediately that there's something wrong with the patient. So again, because these are projectional X-rays, we don't really know exactly where the fluid is along the depth dimension. We kind of just know where it is on the left, right, and the top and bottom, but we don't really know exactly where the fluid is in 3 dimensions. So it takes quite a lot of training, a lot of patience, and a lot of experience for radiologists to interpret and read these plain film X-rays. So let's think about what we can do in terms of imaging technology in order to create 3-dimensional images and make it easier for us to interpret where the fluid is in the lungs. So extending the idea of projection imaging shows basically just one angle through the object. So for example, if you're looking at the hand and your X-ray generator is at the top, then you're basically just looking at one angle directly straight down the hand. But what if we can acquire a series of projections at different angles? So for example, if you rotate the detector, and also you would have to rotate your X-ray source and your detector together. So what if we do that? Then maybe we can get some more information and get a bit more of a spatial localization in three dimensions. So here what I've shown is a CT scanner. So it looks kind of like a donut, like a round device, and the patient goes inside of the donut in the middle, and so there's a patient bed where the patient can slide through the scanner, and within this donut is exactly what I described. So it's basically a X-ray generator and a detector, and they're mounted opposing one another, and they're mounted on a rotating gantry. And so what we can do is we can rotate the two together to get our different projections or different angles. So how we get an image, so let's have a look at how this works. So of course you can get just one projection if you have your detector and your X-ray source at a particular angle, but as you rotate your source and detector, you can get different projections of the object, and the projections are unique for the different angles. And so you get these projections, as you can see on the left. And so if you summarize that in a kind of intensity map, then you get what we call a sinogram, which is basically a representation of the raw data that we acquire from a CT scanner. So you can see here the sinogram has light and dark patches. So those represent the different intensities of the projections, and the different angles as we rotate. Different angles are represented by different lines, horizontal lines, as we move up along the y-axis. So each horizontal line represents a particular angle of projection. So here, what you can notice is the sinogram's a little bit narrower in the middle, and that's because the projection, because the object is oval, it's oval like this, where it's thinner on the kind of top to bottom dimension. The projection at 90 degrees, so for example, right now, is a little bit narrower, and that's why the sinogram is a little bit thinner in the middle. So a sinogram really represents a summary of all the different projections at the different angles. So how do we generate an image from this? It's actually quite clever. So what we do with these projections is we do a technique called back projection, where we smear the projection back onto the image. So how it works is kind of like this. So you take the first projection, so for example, the one from the top down, and then you smear it across the image. And then you repeat the process for every different projection along the corresponding angles. So the second projection will be a little bit off center, and so you smear that down the image. And as you move through the different angles, the more angles you smear across the image, the more the image kind of reveals itself. And at some point, once you've rotated through 180 degrees, then you recover the original image. And so this is kind of extending our idea of plain film X-rays in order to kind of generate. So you can imagine maybe you take a lot of plain film X-rays at different angles, and then you kind of stack them all together, and that's how we get our back projection image. So here we can see the nice reconstruction, and we can see now the signals in 2 dimensions. And if we slide the patient in, so we can either do a step-by-step CT where we do a ring around and then slide the patient in a bit further and then do another ring. So it's kind of like a step-by-step approach. Or the more modern CTs keep going round and round and round. So it's a continuously rotating gantry, and so the patient just continuously slides through, and you get kind of a helical acquisition, and then we can reconstruct a 3-dimensional volume of our patient. So let's have a look at our CT images. So here, showing CT images of our Lyme. So you can see the 3 standard kind of cross-sectional views. So these are kind of because we're doing 3-dimensional imaging now, these are the 3 standard cross sections that we can take of our object. So here I have our Lyme. So the first standard projection is kind of like cutting the Lyme this way. So it's kind of cutting the Lyme, for example, so you can say the Lyme has a head and a foot. So you're basically cutting the Lyme down the middle, separating the head and foot of the Lyme. So that's the axial slice on the left. The coronal slice is if you cut the Lyme sideways like this, horizontally, so that you separate the top and the bottom. So that's the coronal view. And then the last view is the sagittal view, which is if you slice the Lyme kind of, say, like front to back. So say like this is the front, and then this is say like the spine or the back of the Lyme. So if you take a cross section this way, then you get the sagittal view. So you can see inside the Lyme, you can see a little bit of a perhaps like a less dense region, maybe a little bit of a pithy center, but there's not a whole lot of contrast within the soft tissue of the Lyme. So let's have a look at avocado. So avocados have a stone in the middle, and so the stone is much denser than the soft flesh of the avocado, and as you can see here, you get 2 different shades of gray. So this shows that you can see a little bit of contrast with CT, but overall, not a whole lot of features in the avocado. So let's have a look at our starfruit and strawberry. So here's our star fruit. So you can see the nice star shape, and you can see maybe some of the seeds within the star fruit. But again, a fairly uniform shade of gray. And then here's our strawberry, so a coronal view of our strawberry. And you can see on the inside there might be a little bit of air, perhaps, something empty in the middle. But again, the strawberry as a whole has a fairly uniform shade of gray. So now CT uses X-ray energies, and so X-ray has higher energy compared to visible light, and so at the higher energies you can cause a bit of radiation damage. So this is high enough energy that it can cause ionization, and it's even higher energy than ultraviolet, which is slightly higher energy from violet, from the visible light. And so some of you may have experienced sunburn before. So that's basically damage to your DNA due to ultraviolet radiation. So these are X-rays, which are a bit higher energy than our ultraviolet radiation. And so these can also cause damage to our DNA. So we have to be careful when we're doing CT not to expose you to too much radiation. So we'll talk a little bit more about that later. The last modality that we're going to talk about is magnetic resonance imaging, or MRI. So, of course, magnetic resonance imaging requires a magnet. Let's have a look at some magnets that we have and how strong the magnets are. So the strength of a magnet is measured in a unit called Tesla. And the Earth's magnetic field is 0.005 Tesla. Okay, so how strong do you think a fridge magnet is? So I'm seeing kind of numbers like 1 Tesla, 5 Tesla, 0.1 Tesla. Okay, so fridge magnets are actually not that strong. So fridge magnets are kind of 0.002 Tesla. Okay, how about this magnet? So this is an electromagnet that is used at a junkyard to pick up scrap metal. So how strong do you think this magnet is? Okay, again, I see kind of 1 Tesla, 5 Tesla, 10 Tesla. Okay, so this is actually not as strong as you might think, but 0.5 Tesla, so half a Tesla. So how strong do you think clinical magnets are? So I see kind of 1 Tesla, 1.5, 3 Tesla, 5 Tesla. Okay, yeah, that's pretty close. So the most common magnetic field strengths for clinical MRI scanners are 1.5 Tesla and 3 Tesla. So these are quite a bit stronger than our fridge magnets, and they can be quite powerful. These magnets are quite powerful. If you bring a metal object into the magnet, you can definitely feel the pull, and sometimes it will just rip the object out of your hands and then stick to the inside of the scanner. So these are quite powerful magnets. There are even more powerful magnets in research, and also some of these higher field strengths are now becoming more common in the clinic. So, for example, in Oxford we have a 7 Tesla human clinical scanner, so a whole body scanner. And we have even higher fields. So here, 11.7 Tesla scanner. But this scanner is in the research lab. But they do have some companies are now producing head-only scanners that are at these higher fields, like 9 Tesla and 11 Tesla. So, okay, so these are our magnets. So next question: are strawberries magnetic? Vote in the chat. Y for yes, N for no. Okay, so I see a mix of yes and no. So here's our strawberry, and here's a bar magnet. So, you know, it's not so magnetic. it's not as magnetic as, for example, this spoon here, where I can basically lift the spoon with my magnet. But is a strawberry magnetic? Well, it turns out it is. So here is a video showing magnetic levitation of a strawberry. So it turns out if you put a strawberry in a vertical magnet that is, so I think this is above 14 Tesla. So maybe this is something like 15 or 16 Tesla. So if you put the strawberry in a strong enough magnet, it actually floats. So how does this work? So we have materials that so normally in everyday life we kind of think of materials as either magnetic or non-magnetic. The objects that we think are magnetic are mostly ferromagnetic, which are a lot of metal objects. For example, the spoon is ferromagnetic, and so it's strongly attracted to the magnet, so it sticks to the magnet. Another type of material that is magnetic in a kind of conventional sense, and that it sticks to the magnet, are paramagnetic materials. So these are a little bit more exotic and not so common in everyday life. Paramagnetic materials tend to be kind of elements, like simple compounds, certain metal ions. And one common one is oxygen. So because oxygen in everyday life is usually in the gaseous state, we don't really notice the magnetic properties. But if you can condense the oxygen down, so if you can cool down the oxygen and condense it down into a liquid, then you see quite a magical property. And this comes about from the chemistry of oxygen. So oxygen is a diatomic molecule, so it has two oxygen atoms bonded together by a double bond. And so you can see here in the electronic configuration that there are two unpaired electrons, and these give rise to the magnetic property of molecular oxygen. So let's have a look at this video, which shows liquid oxygen. So this is oxygen gas that's been condensed and cooled down to a liquid. So as you pour the gas, pour the liquid oxygen down in between the two poles of the magnet, you actually see the liquid sticking to the magnet. And so, so this is kind of our normal sense of what a magnetic material is that it sticks to the magnet. So it turns out molecular oxygen is actually magnetic, but it's not strongly magnetic. So this is kind of an intermediate state that we call paramagnetism. And then the third class of magnetic materials is what we call diamagnetic materials. So these are materials that are quite weak usually in terms of having a response to like an attraction to a magnet. So objects like our strawberry here would be considered diamagnetic. And so how does it work when we put these objects in a magnetic field? So when we put these objects in a magnetic field, what the ferromagnetic objects would do is it would experience an induced magnetic field that is pointing in the same direction as our external magnetic field. And the same thing happens to our paramagnetic material, such as liquid oxygen. So if you put it between the two poles of the magnet, the liquid oxygen becomes slightly magnetized, and it has an induced magnetic field that points in the same direction as our external magnetic field. Diamagnetic materials are the opposite. So they point in the opposite direction to our external magnetic field. And this allows us to levitate diamagnetic objects under certain conditions. So how do you levitate a strawberry? So you need a very, very strong magnetic field, and you put a strawberry down into the magnetic field vertically, and what happens is you get an induced magnetic field that points in the opposite direction. So here, the north pole of our strawberry is pointing towards the north pole of our external magnetic field. And so there will be magnetic repulsion. And so if you look at a free body diagram to look at the forces, of course, you have the force of gravity pulling the strawberry down, but you also have a force of magnetic repulsion pushing the strawberry up. And so if you have a equal force, so if the force of gravity is the same in magnitude as the force of the magnetic repulsion, then you get a state where the strawberry is feeling no net force, and so it basically just floats in midair. So it's quite a remarkable phenomenon. So of course, larger objects will experience a larger force of gravity, and so you can only really levitate objects with the currently achievable magnetic fields. You can really only levitate small objects like strawberries and small diamagnetic objects. So here are the different parts of a clinical MRI scanner. So on the left here, you can see the patient on a patient bed. And again, it looks like a donut-shaped machine. So it looks very similar to a CT scanner, but on the inside, it's quite different. So on the inside of the MRI scanner, of course, you have the magnet. So the magnet has kind of these wires, these superconducting wires wrapped around in a cylindrical shape. And these wires are usually submerged in a very, very cold liquid, a cryogenic liquid called liquid helium. And so this keeps the resistance in the wire to a minimum. And if we get the conductor cold enough, then it becomes superconducting. So it's a special kind of material where when we cool it down to liquid helium temperatures, it becomes superconducting. The resistance go to zero or to very close to zero. And basically what we can do is we can have a current that runs along the conductor permanently. And so the magnet is always on because the current is always running, because there's no resistance to dissipate our current. And so MRI scanners are always at field. They're always on. You can't turn an MRI scanner off with a flick of a switch. So inside our magnet are gradient coils. So what gradient coils do is they create a imbalance in the magnetic field, and this gives us spatial information, because if the magnetic field is the same everywhere inside the magnet, including everywhere throughout our object, then you don't really get any spatial information. So if we make the magnetic field inhomogeneous in a controlled way, for example, we can have kind of a linear ramp where the left side of the object, for example, can experience a slightly lower magnetic field than the right side of the object. And so in that case, we get a little bit of spatial information, because the left side of the object will emit signals that are experiencing a slightly lower magnetic field versus the right side of the object, which is experiencing a slightly higher magnetic field. And so this gives us this allows us to encode spatial information in our signal, and then we can use computer algorithms to generate images. So how do we acquire the signal? Well, we acquire signal using a radio frequency coil. So these come in a variety of shapes and sizes for different applications. So on the top left there, we have a head coil. So you can see it's a nice round cylindrical coil where we can have the patient's head nicely placed inside, and so we have a lot of elements all the way around the patient's head for a good signal acquisition. And then in the top center, we have a pair of surface loops. So these are kind of general use loops. So we can put these loops, for example, on the chest to look at the heart, or we can put it on the abdomen to do liver imaging. So these are kind of very general use coils. So they're not as homogeneous as for example, the head coil, but they are a bit more flexible and a bit more portable, so you can put it in different parts of the body. On the top right is kind of a board-shaped coil. So this is kind of a compromise for the abdomen between like a nice homogeneous uniform radio frequency excitation, where if you have one element at the top and one element at the bottom, then it's almost kind of like a all the way around coverage of the body. So these are used for kind of abdominal imaging. And then the bottom left, we have a knee coil. So this is specifically looking at the knee or the kneecap or the upper thigh. And then in the bottom middle, we have a top and bottom leg coil. So these provide a bit more homogeneous signal acquisition. And then on the bottom right is a endorectal coil. So this is a coil that we can use to insert into our body cavities. And in this case, we can look at diseases such as colorectal cancer or prostate cancer. And because the coil is much closer to the anatomy that we're trying to image, it provides better signal and allows us to obtain images with higher spatial resolution. So how does signal acquisition work? So we use radio frequency coils, but how do we use them? So MRI signal comes from hydrogen, in particular the nucleus of the hydrogen. And we have a lot of hydrogen in our body because we're mostly made of water, and each molecule of water has 2 atoms of hydrogen. So hydrogen atoms have an intrinsic magnetic property. So these behave kind of like bar magnets. And without an external magnetic field, the bar magnets, kind of like compass needles, just point in all sorts of random directions. Now, when you put the patient inside the MRI scanner, the bar magnets tend to align now with the magnetic field. But due to quantum mechanics, the bar magnets are always spinning. So they're always kind of spinning around. The problem is they're spinning around with different phases. So what that means is some of them might start out on the left side, some of them might start on the right side, and then they're kind of rotating, but they're out of phase. So they're not in sync with each other. And so overall, the signal from all of these different hydrogen nuclei get canceled out. And so we see no net magnetic signal coming from them. So what we do is we use a radio frequency. So this is at the lower end of the electromagnetic spectrum, at the lower energy range. So this radio frequency is below the energy of visible light. It's also below the energy of microwaves, so it's quite a low energy electromagnetic radiation. And so what we do is we use the coil as kind of a very strong radio station. So you can imagine kind of a broadcasting station, but instead of using an antenna where you broadcast a signal sideways and in all directions, with a coil, you're broadcasting the radio signal in a more directed manner into our object. And kind of like ultrasound, you can use the same radio frequency coil to receive the response as well. So you can receive the magnetic response when you excite our hydrogen nuclei. So let's see what happens. So when you apply this radio frequency excitation, what happens is you're kind of driving everything in phase, and so now when the spins are rotating, they're actually rotating in phase, and they add up together. So this is what is known as coherence. That is producing a net magnetization. And what we can do with this net magnetization is we can use our radio frequency coil and kind of receive the induced voltage. So the rotating magnetization in our object will induce a voltage in our radio frequency coil, and we can record the voltage as a function of time. And this is our magnetic resonance signal. And so basically, this is quantum mechanics. So you've basically learned quantum mechanics and how it works in terms of in practical use. So quantum mechanics is not just a theoretical subject. It's actually quite a practical part of physics as well. Okay, so let's have a look at the images of our patients. So let's start off with strawberry. So you can see a very nice image of the strawberry. So you can see a bit more features compared to the CT scan that we saw earlier. So you still see kind of a hollow center in the strawberry, but also you see kind of where the seeds would be. So you don't see the seeds. So the reason why you don't see the seeds is because the seeds tend to be dry, hard and dry, and so you don't have very much water in the seeds, and so because your signal comes from water, the seeds look more or less invisible on MRI, but you can see the indents, you can see kind of the the spots, the places where the seeds should go on the surface of the strawberry. Okay, and then starfruit looks spectacular. So this is just an exquisite image, detailed image of what's inside a starfruit, in my opinion. So you can see the fivefold symmetry of our starfruit. You can also see the seeds in the starfruit. So this is just a very beautiful image of our two subjects, of our strawberry and our starfruit. And then looking at lime, so you can actually control what kind of image you get with MRI. So unlike CT, where your image is more or less determined by your object, in particular the density of the object, in MRI you have more control over what kind of image you will get. And so by changing certain parameters on the MRI scanner, we can effectively acquire different looking images. And this is very useful because different kinds of cancers, different kinds of tumors have different properties. And so by tailoring our imaging to a particular type of cancer, we can get better images, more detailed images of specifically for that anatomy. So in this example here, we can have images of lime with or without pulp. And looking at avocado, so we see very nice soft tissue features in the avocado. So here, there might be a little bit of fibrosis in the avocado, but you can control the contrast to either get a dark stone or a bright stone. So this is quite remarkable, and this kind of shows the flexibility of MRI as an imaging modality. So compared to the CT, again, so these are two images, CT and MRI of Lyme. So compared to the CT, you tend to get better soft tissue contrasts with MRI. But as I mentioned, CT uses X-rays, and X-ray is a high energy electromagnetic it's a higher energy along the electromagnetic spectrum, and so with CT, there's a risk of ionizing of the ionizing radiation causing damage, causing injury due to damage of your DNA. Whereas with MRI, you're actually using the lower energy end of the electromagnetic spectrum. So you're looking at kind of radio frequency, which is even lower energy than microwaves. So basically right now at this moment, a lot of radio frequency, there's a lot of radio frequency electromagnetic waves passing right through me, and through you as well. And you don't really notice it because radio waves are such a low energy that they very, very weakly interact with the molecules in our bodies. In this case, what's going on with the radio frequencies is that they kind of rotate the magnetic moments of our hydrogen around, but that doesn't really do very much. So in terms of DNA damage, there is no DNA damage from radio frequency excitation. So CT, on the other hand, uses much higher energies, and so there is the risk of DNA damage. So these are kind of the two contrasting factors in terms of deciding which one to use, because they're both three-dimensional imaging modalities. But the CT, for example, because of the risk of radiation damage to the DNA, CT is usually not recommended for example, mothers who are pregnant, and also younger patients, because there's a greater lifetime risk of cancer if you expose younger patients to ionizing radiation. Whereas MRI, on the other hand, because it uses a strong magnet, certain patients might not be eligible to have an MRI. So for example, if they have a metal implant, or if they have a pacemaker or some sort of implanted electrical device, or sometimes even if they have a tattoo, which may have metal fragments or metal particles in the ink, then for these patients, they may be contraindicated for MRI because there are risks. For example, the metal implants, if they're magnetic, can be pulled so they can feel forces from the magnetic field, and that can cause mechanical injury. Or if the implants, even if they're not metallic, so for example, titanium implants are not ferromagnetic in the sense of having a strong attraction to the magnetic field, but these metal implants can heat up with the oscillating gradient and also with the radio frequency excitation. You can heat up these metal pieces in the body, even though they're not attracted to the magnetic field, and this can cause quite a lot of damage. So every patient that comes in has to be screened in order to assure that it's safe for the patient to undergo MRI. And so CT, on the other hand, is quite a useful technique in the emergency context. So at the A&E, if someone might have experienced an injury due to an explosion, for example, and they may have metal shrapnel in their bodies, then a CT is a much safer option, which can show where the shrapnel is, or if there is shrapnel or not, compared to an MRI, where if we don't know the condition of the patient, then it's quite a high risk of injury if you put a patient with metal shrapnel, for example, in the body and into the MRI. So today I've presented 4 different modalities. Of course, there are more imaging modalities, but these are kind of the main ones that we use in the clinic. So we've looked at optical imaging, we've looked at ultrasound, computed tomography or CT, magnetic resonance imaging or MRI. So I'll just ask you a few final questions about this. So which imaging modality do you think is the fastest? 1, 2, 3, or 4? So I see a lot of ones coming in, so that is correct. So the optical image is the fastest. The ultrasound is not bad, but the optical image is imaging at the speed of light, whereas ultrasound is imaging at the speed of sound. So even though in practice both of them are more or less in real time, and with ultrasound, actually, instead of getting an image, you actually get a video. So the two types of imaging modalities are more or less real time in practice. And so which imaging modality do you think is the slowest? So I see kind of a mix of 3 and 4s. So CT is actually a bit faster than MRI. So MRI gives you very beautiful soft tissue images, but it takes quite a long time to acquire an MRI. So in terms of a clinical scan, going through the 4 different modalities, optical is basically instant, and it's the same with X-ray imaging. So plain film X-rays are basically instant. Ultrasound, again, is pretty instantaneous. So as soon as you put the transducer onto your object, you start seeing images or a video, I guess, of the object. CT, the normal kind of clinical exam, CT takes about 5 to 10 minutes. So it's quite a quick modality where you put the patient on the table, you send the patient through. There's not a whole lot of parameters to change. It's more or less kind of a push button type of technique. So it's kind of a one size fits all, same imaging parameters for every patient. And so it's quite a quicker imaging session compared to MRI, which can take anywhere from half an hour to an hour, and sometimes even more. So it takes quite a long time to acquire MRI. So these are different trade-offs that you have to consider when you're choosing which imaging modality to use to look at specific diseases or conditions of your patients. So in the final 2 slides, what I'll do is talk a little bit about the research that I do in Oxford. So what I do is I look at metabolism and specifically metabolism in the heart. So metabolism is interesting because if there's any sort of abnormality or injury to the tissue, then usually the first thing that you notice is a change in the tissue's metabolism. So for example, in the case of a heart attack where you block a particular artery that supplies blood to the heart, to a particular part of the heart. So this can happen through plaque buildup, or if there's some sort of clot, then that can block an artery. And so without blood flow, the heart will change how it responds to generate energy. So in this pathway, what I'm looking at is kind of a little bit further downstream of sugar metabolism. So when you eat, a lot of the molecules in your body get turned into glucose, as they get broken down into glucose, which is a 6-carbon molecule. And then further down, after the process of glycolysis, you get from one molecule of glucose with 6 carbons, you get 2 molecules of pyruvate with 3 carbons. And pyruvate is at a very interesting branching point where, depending on whether or not there's oxygen for example, in muscle, you can have 2 different outcomes. So if you have oxygen in healthy muscle, what you get is the pyruvate gets converted into carbon dioxide and water, which is kind of the normal respiratory process that we think about. So in this case, when the label pyruvate gets converted into labeled carbon dioxide, then the carbon dioxide is in rapid equilibrium with bicarbonate, which is an endogenous chemical equilibrium that controls pH in our body. And so what we can see is a signal from bicarbonate. On the other hand, if you don't have oxygen, what muscle can do is temporarily use a process to generate lactic acid, and this results in a production of a little bit of energy, so not as much energy as you would produce if you had oxygen and if you converted pyruvate into carbon dioxide and water, but you get a little bit of energy by converting pyruvate to lactic acid. And if you've ever experienced kind of exhaustion, where if you've been running very, very hard, then some of you might have experienced some pain in your muscle, and that's due to lactic acid buildup. So you've basically depleted your reserve of oxygen in your muscle, and you start to undergo this anaerobic respiratory pathway to generate lactic acid and a little bit of energy, but you can't keep this up forever. And so at some point, you produce too much lactic acid and the muscle stops functioning. So what I do is I use magnetic resonance and a special looking at, instead of looking at hydrogens, I'm looking at a special isotope of carbon. So this is a non-radioactive isotope of carbon. But what we can do is we can acquire images of carbons similar to what we get with hydrogen. And so what I'm showing here is kind of a cross-section through the heart. So if you think about the heart as shown on the left, and you take a cross-section, then you can see the heart muscle as kind of like a ring, and then you can see the chamber as well inside the heart. So you can see here the pyruvate on the left is mostly localized to the chamber, so it's mostly in the blood, but the bicarbonate and the lactate signals come from mostly the muscle. In the heart. And so what you can see here is a little bit of a missing chunk in the bicarbonate image in the middle. So at the bottom of the image, you see the ring is incomplete. And so that indicates that in the bottom part of that ring, that part of the muscle is not undergoing aerobic respiration. Now, looking at the lactate image, you see a similar thing where you have a decreased signal at the bottom. So what that kind of indicates is that perhaps the heart is still receiving some perfusion. So some of the pyruvate is getting to the muscle at the bottom, but perhaps that part is not receiving very much oxygen, and so maybe it's undergoing more of a conversion to lactic acid than to bicarbonate. And so this is a patient who recently experienced a heart attack. And so with this technique, what we can look at is whether the muscle, we can predict whether the muscle that is affected by the heart attack, whether that is viable. And if it's not viable, then this tells us that by doing interventions to restore blood flow will not work. And so this is quite an important determination in the clinic, where if the procedure is not going to work because the tissue is just dead and not viable, not recoverable, then there's no point exposing the patient to further risk of a procedure. So I believe that this is quite a novel and emerging technology that will change how patients are receive the most appropriate treatment for their condition. So in the last slide, I'm going to talk about diversity in medical research. So you can see here, you can't do medical research by yourself. You need a large team in order to produce good research. And so here you can see a diversity in expertise and diversity among the team. So here we not only have clinicians, which are the cardiologists, the radiologists, but we also have scientists. We have natural science expertise. So here we have some physicists, we have some biologists, some chemists, we have a veterinarian, and we also have computer scientists. And in addition to that, we also have a pharmacist and also the pharmacy technologist team. So within this diverse group of people, we have basically complementary skills and knowledge and expertise in order to produce good research in medical imaging. And so I would encourage you to explore your interests, to see what you're passionate about, because there are many routes, many different pathways where you can still end up doing medical research. And in the natural sciences, for example, the benefit to the patient might not be so direct as if you were a clinician, where you're directly treating individual patients. But if you develop a technology to help patients, then you might have a larger effect on the overall health of the population compared to, for example, treating individual patients in the clinic. So it's a different perspective, I guess, on what you can do in terms of medicine and in terms of improving the health, improving global health. And so there are many different pathways that lead to medical research, and medical research and medical imaging in particular. So I would encourage you to follow your passion, apply to medicine, but also apply to natural sciences if you're passionate about natural sciences, because there are many ways you can contribute, and we do need all the diversity of expertise. We need our biologists, our chemists, our engineers, our physicists, our veterinarians. We need the whole range of diverse skills and expertise in order to produce good research. So in the last part of this presentation, I'm going to perform a little bit of surgery to have a look at the optical image. So this is a little bit of a cheating, I guess, because medical imaging is designed not to be invasive, but let's have a look at the optical images and see how they compare to our MRI images. So here I'm looking at our Lyme. So you can see here, here's the optical image of the inside of the Lyme. So of course you can see it's a very high spatial resolution because it's optical imaging. It's also instant, so you can see it right away. but basically you have to cut the lime open in order to see it. Okay, let's have a look at avocado. So let's have a look and see how it is. So here's what the avocado looks like. This is kind of a coronal or sagittal slice, I guess. So you can see maybe a little bit of fibrosis in the avocado, not too bad, and then you can see the seed in the middle. And then our star fruit. So you can see here there's a seed right there in the middle of the star fruit. So you can see a very nice star shape. And then finally, our strawberry. So cut open the middle. So you can see here, there is indeed an air gap in the strawberry. So the CT and the MRI agree with the optical image. So I hope you've enjoyed this presentation, and I hope you've learned a little bit about medical imaging, and also a little bit about possible careers in medical imaging research or medical research in general, and hopefully this will help you think about what you want to do as a career as you begin your application to university and begin to explore what you want to do as a career. So thank you very much for listening, and have a nice day.